Evening, everyone, and welcome to Gyan Pravah podcast series, episode number 280. I, Dr. Sita Ramamurthy Pal, the chairperson of the Genetics and Fetal Medicine Committee, Fogsi, welcomes you to this podcast series, which is basically a flow of knowledge, Gyan Pravah, where on the 4th of every month, I bring to you we discuss about various topics on fetal medicine and beyond with different illustrious experts. And today my guest speaker is none other than Professor Asma Khalil, who's an expert in fetal medicine, who's very well known in India and across the globe. And the topic for today is training in fetal medicine, overcoming challenges across borders. So thank you, Dr. Asma, for accepting our invite and welcome to our podcast. Before we start the podcast, I would like to formally, of course, introduce our president, Dr. Sunita Tandulwadkar, whose this podcast is a brainchild, and we have reached this far, 280. You can imagine from the 31st of January, we are going strong, and every evening, Madam makes it a point to join and encourage us where different topics are discussed. And beyond this, there's a lot more to her, like different projects of hers going on in this year of Sampurna, which is basically the holistic care of a pregnant woman, starting from preconception and beyond, the area of HPV vaccination, the combining spirituality and medicine, and lots more and beyond. Well, of course, she's a great laparoscopic surgeon and infertility specialist. But thank you, Madam, for giving us this opportunity, this platform.
Sita, this is your day with Asma.
Thank you. So please welcome us.
Thank you so much, Sita, for your kind word. Asma, welcome on a Fogsi platform. Anything happens in Fogsi, Asma has to be with us.
Yes.
Your educational standards, your academics, always you make us feel so comfortable, so learned. So this podcast is every day 8 p.m. Asma. I have a 30 committee chairpersons. So on 30 days, every one they have been given a fixed one date. So like Sita is on 4th of every month. And this is happening. So 280, 280. It's a huge number. It's quite challenging, taxing. Initially, I thought 30 committee chairperson, giving them a platform, 1 hour discussion. The faculty can be from academic or non-academic. So we had even the actors, we had politicians, the central ministry. We had so many philosophical and spiritual gurus on this platform. And more than my committee chairpersons, I feel I evolved as a person. There is so much to learn from each and every individual, especially the non-academic. When I meet them, their way of thinking, their way of life, their way of working evolved you as a person. So it's a beautiful thing. My chairpersons are fantastic, Sita. You are always, what is most important, the Fogsi, Asma, everything about Fogsi. But it is a very well-formed foundation. And 30 chairpersons, they work with the president very closely. So they do so many activities on weekends. They are doing the CMEs with our presidential programs. So my preconceptional care, they are. So people say that there are 8 programs which has happened on weekends because my 8 committee chairpersons are traveling in different directions. So the president always get blessed to have the best of the chairperson. And Sita is one of the most dependable, hardworking, trustworthy. Anything I need on academics with the fetal medicine, I just tell Sita, you have to do this one write-up for me. And the time given to you is 12 hours. Sita sit whole night and work. That is what the commitments of the chairperson are. And they are the future leaders of Fogsi. So I love them all. And Asma, you are such a dear friend and you look so young, like a college going girl. For ages together, you look the same. You don't age only. And it's always great. And I'm sure the Delhi ASUG also must have pulled you down. And Bhaskar will not leave you because I'm handing over to Bhaskar. And it will be always great to hear the dialogue between both of you. Our pattern is I just welcome and show the respect to the faculty for coming on a Fogsi platform. And I also join the viewers link so that both of you are only in the dialogue and we listen to you, the important. And Sita has always taken fetal medicine as a topic for her every podcast. So she is educating everyone in this field, and today training, I'm sure many more youngsters will join. This is a global, so you please share the link with Asma so that she can share it to future her all people in RCOG. Thank you so much once again, and I will join the viewers link. Thank you, Asma. Thank you.
Thank you very much. Thank you for having me.
Thank you. Yeah, so this podcast is actually recorded, and so I will share the link with you once we are done. But thank you, Asma, and it's now my honor and privilege to welcome Professor Asma Khalil, who's a very well-known figure, as I said earlier, who's the Professor of Fetal Medicine at the St. George's Hospital, University of London in the United Kingdom. She's the Director of Fetal Medicine Unit also at the Liverpool Women's Hospital, the Vice President of the Royal College of Obstetricians and Gynecologists. She's actually the obstetric lead at the National Maternity and Perinatal Audit, and she gained her MD at the University of London in 2008. Professor Asma is a brilliant academician, and she has published more than 500 peer-reviewed papers and many published review articles and chapters. She's been awarded many research prizes both at national and international meetings, and in fact, she was awarded the 2021 FIGO Women's Awards, which recognizing the female obstetricians and gynecologists. As we all know, her research interests include twin pregnancy, congenital infections, fetal growth restriction, and hypertensive disorders in pregnancy. She's had a fellowship with the National Institute of Health and Care Excellence, and she's committed to the implementation of clinical guidelines in practice. She's the lead author of the ISOA guideline on the role of ultrasound in twins and congenital infections, which is our Bible. I think we all read it day in and day out. The different guidelines that come through has been such a big help to us, to different people in all across the country and across the world. She also has led the guideline team developing the FIGO guidelines on the twin pregnancies, and she was a member of the NICE guideline committee, which updating the twin and multiple pregnancy guidance. But beyond all this, despite her brilliant academic career and her academic accolades, she's a very humble person and very approachable. And as Dr. Sunita Tandulwadkar said, she's a very dear friend of all our Foxians and is always ready to help us with all our academic activities. So thank you, Professor Asma, once again for joining us in this podcast.
Well, thank you very much for having me. It's a real pleasure. And I always say it, I love going to India, and it's proud of having many friends and colleagues from India. India is an admirable country in terms of what they achieved and their work ethics. I mean, India, look, fourth largest economy in the world. There's always, if I describe the doctors or my colleagues or friends there, they work hard and they also party hard, which is always, as I said, it's always a pleasure to go there and spend some time with them. And obviously recently with my role as Vice President of the Royal College of Obstetricians and Gynecologists, obviously India is the second largest region for our global membership or our non-UK membership, and we have very, very close, obviously, relationship with India, which meant that I tend to have more visits to India and also welcome several colleagues from India in the UK.
Yes, it's always a pleasure having you in India with all, and we look forward to your talks and your interactions because it gives us so much knowledge more to gain. And as you said, being the Vice President of the Royal College, the training aspects also has come into place, how we can exchange the various, and this is what we're going to talk about today. So as we start the podcast, can you tell us, because, we all begun our career as basically obstetricians and gynecologists. So what was your interest in, or your journey into fetal medicine? What sort of made you go into fetal medicine specialist as in the beginning?
Okay. Well, training in fetal medicine, it's really one of the most rewarding journey in obstetrics, but also one of the most demanding, because it doesn't just it requires not only the clinical skills, but also, the technical precision, the compassion, the resilience, the deep commitment to lifelong learning. It's the only specialty, I would say, that you have to treat two, sometimes more patients at the same time. And sometimes you have to really balance the interest of one patient versus the interest of the other patient. So the interest of the baby, for example, versus the interest of the mother.
Yeah, yes.
And I think that's a very unique specialty. It's also the only specialty that you really can have a day at work where you start with, you have a feticide, followed by doing transfusion, saving baby's life, followed by putting a shunt, for example, because you've got high drops and pleural effusion and the baby will die unless you intervene, followed by another feticide, followed by giving bad news and telling the parents, the baby's going to have severe disability. So it's the ups and downs. And after all of this, after that day, which is quite common, that you need to go and have your life. Is it? And look after your kids or go and socialize with your friends or go to a party. So in terms of the emotional toll, how much actually, and people don't talk about that, about what actually the aspects of the doctor and how they cope with that. And in the last few years, especially with the COVID-19 pandemic, I think this emotional well-being of the staff or the healthcare professionals has really become important and something that people talk about in every day, but also in conferences, also my role as RSOG. So it's something that when I was a young trainee was never really something that people talked about or actually been seen as something important. But back again, what brought me to fetal medicine compared to other specialties? It goes back to when I was a medical student, that's many, many years ago, when I actually did attachment in University College London Hospital, and Professor Charles Roddick, who is one of the fathers of fetal medicine, and I watched him doing a blood transfusion, intrauterine fetal blood transfusion. And that really that day I was so excited. I was talking to everybody about what I saw. And really, sometimes you reflect, on what you see, and this concept of saving life before even birth.
Yeah.
So, if this baby did not have transfusion, the baby would have died. And the fact that you're doing an intervention or surgery that actually gives this baby hope for life before even this baby is born. So that's a concept that really sort of resonated with me for the rest of my career and rest of my life. So that's what made me really passionate about the specialty.
Oh, that's nice. Yeah, as you said, it's something very rewarding at the end of the day. And IUT being such a successful intrauterine therapy, that really puts you. But how is the structure training in the UK? I mean, what do you think in terms of what skills does it focus most? Or what do you think every fetal medicine specialist should develop during training in terms of their core competencies? Because there's something that's slightly different, as you said, from when we learn obstetrics and gynecology. So what area should training in fetal medicine focus on? And you think we can combine both together? Because again, there's one area I'll ask this after you answer this question.
Yeah, sure. I mean, I think one of them, I said, it's extremely rewarding, but it's also quite challenging because fetal medicine is a specialty that really have interface of several disciplines. Yeah, so you've got the obstetrics, but also you've got the neonatology, you've got the genetics, you've got the imaging, you've got the surgery. And therefore it is this multidisciplinary approach. So part of the training is actually how to work as a team and define your role and value the contribution of each of members of this team. And certainly when we have our regular multidisciplinary meetings, so we have weekly, we have this contribution and we learn from each other and contribute to each other. I think also fetal medicine, and there are several challenges, but one of them is the pace of innovation, advances in ultrasound, actually the technology itself, genomics. I believe that genomics should be an integral part of the fetal medicine training. You need to have not just basic, but if you're really going to be a subspecialist, for example, in fetal medicine, you really need to have advanced level of knowledge about genomics. And then, of course, the new kid on the block, which is artificial intelligence. And artificial intelligence, has become an integral part of our everyday life, but also everyday clinical practice. But I think certainly AI, I believe that is one of the major role for AI is imaging. And it's already happening, sort of when you buy any new ultrasound machines, you will have AI integrated into it from, the AI, the biometry or the AI actually looking at identifying the planes, actually even helping with the training by sort of, setting the standards and helping the person, the operator, see what the standard should be, and also helping with audit in terms of your practice. So AI will play a major role and is already playing an important role, but I think the challenge where you define the AI, the validation, how is that actually is it gonna replace the sonographers? How it's gonna actually help us becoming better doctors or being better healthcare professionals? So the challenge of sort of in terms of the training in the UK, I mean, the UK has really led, I would say, the world when it comes to fetal medicine training. If you go back to the history, in terms of having really standards for ultrasound training and curriculum for fetal medicine training that's structured and competency-based, and defining the different sort of levels of fetal medicine training, where sort of the subspecialist the HSM or sort of, a specialist, but not necessarily subspecialist, and defining the role of each member or each healthcare professional. Is it perfect? No, by no means is perfect. We also have several challenges when it comes to fetal medicine training in the UK, particularly when it comes to training in procedures and fetal medicine procedures. And I think the challenge has several aspects to it. Is that number one, the number of those procedures, they're not many, and they're centered in sort of the certain fetal medicine centers, and they tend to be obviously regional centers. I think for if you compare, for example, India to UK, and I said that I do love India, so India has a special place in my heart. And India has many advantages. Is the fact that you've got the numbers. It's a massive country. There's still sort of obviously a large number of births, and therefore I never worked in India as a healthcare professionals, but certainly I'd expect that the demand exceeds the capacity.
Yeah.
Correct. So I think you have many patients, and therefore the opportunity for training is there. I think the challenge is access, because I suspect sort of knowing the centers where the fetal medicine training is available, again, they tend to be in sort of centered in certain, probably the large cities. And therefore, what about women in the villages? And that's not just in India, that's many parts of the world, And what about these women who this baby has a problem and requires maybe, help or assistance? How would we ensure that these women have access to the ultrasound, to the operator, to the expertise, and perhaps maybe therapeutic procedures? So that's where the challenge, I think, and how, the super specialization versus democratizing and access to and getting the services where the need is.
Yeah.
And so I think in the UK we do have a challenge in terms of ensuring that the healthcare professionals or the fetal medicine specialists have the training and the expertise in doing therapeutic procedures.
Absolutely. So in that respect, do you think simulation, that has come through, has it changed how training is delivered? Because in India also, earlier we used to have, free access, but again, nowadays it's become difficult where we used to practice on patients that can't be done nowadays. So everything is changing now, and I think in the UK it's the same. So how do you think simulation-based training has come in all aspects of subspecialties? What do you have to say about that in fetal medicine? And that's also coming up in a big way, isn't it?
Yeah, and to some extent, I was, I'm proud to say that a few years ago, I really felt that there was a need, and I sort of took that on and started doing fetal therapy or fetal intervention hands-on course using simulators. And I really think that despite the fact that I said fetal medicine has, or particularly the UK led really in terms of fetal medicine training, I think actually fetal medicine lagged behind when it comes to simulation. Because if you look at other areas like laparoscopy, for
Yeah.
example, where actually simulators are really advanced, and in many parts of the world, the trainee or the obstetrician gynecologist or the youngest trainees, they actually go to and do a lot of laparoscopic simulation training before they actually get to the theater, and therefore they do have already good the coordination, the hand-eye coordination, a lot of the skills already they have acquired before they actually start operating on patients. So and certainly in the last few years, there's been tremendous advances and interest in ultrasound training using simulators, but also in simulation on fetal therapeutic procedures or fetal interventions. And actually, obviously, you have very successfully organized a number of training, and I was participated in some of that, and it was like excitement. Certainly, it was extremely successful, where you managed to assemble a large number of the trainers, the fetal medicine specialists, the people who have the expertise, coming on a weekend where you've got the simulators, and it's one of the really good companies that really innovate when developing simulations specific to fetal medicine procedures, and actually having the people who are training or at various stages of training actually coming to practice. So I think simulation, I think, is likely to play an important role.
Yeah, true. Because as you said, in endoscopy, it's only about procedures, but fetal medicine is also about imaging as well as the procedures. So the ones when we start training for imaging, for doing the ultrasound, that is also a challenge when we do have the volumes, but sometimes training on patients becomes difficult. So even the imaging bit, we do it on simulators, and even the procedural aspects, we do it on simulators, which is coming up in a big way. As you said, fetal medicine is a very complex subject. It needs a lot of counseling. It's about all these tests that we offer, and talking to the patients. So, and a lot of the high stake decisions need to be taken. And when obstetricians become their focus, primary physician, and when we come into the picture, how do you train these our trainers to handle these sort of emotional aspects about counseling? Do we think that should also be included in our training? Because that sometimes becomes a different aspect of not obstetrics counseling, but different aspect here. So what are your thoughts on that?
Yeah, I think this is a really important point, and as of the beginning of our conversation, I did say it's something that when I was a trainee or a young doctor, that was never really something that sort of have been important. And you just part of your training, you step up and you go through that, and that's just part of developed as a doctor. And that has changed, particularly in the last few years, where really the well-being of healthcare professionals or doctors have become, very important. And I think that's, if I would remember well, I think that sort of was maybe around the time of the pandemic really started. And again, back to my RSVG, the vice presidency role, there is also lots of, we developed a lot of well-being resources to help supporting doctors. And again, I said, there's something that I really realized in the last few years, is resilience, and how you develop that, and how you, I nowadays more and more often I would say that you need to look after yourself to be able to look after your patients well. Because I've seen it, and I've seen it on a sort of personal level, but also on, people that you work with, is that when healthcare professionals or doctors, are go through stress, whether at workplace, whether on personal life, whether the family, the kids, they certainly affects the way they work and the way they interact with their colleagues or their patients. Okay, and actually doctors, again, traditionally, they are not open about their feelings and about how they are struggling to cope with things. And many people will perceive that as like it's a weakness, is that you've been looked at, as if you cannot cope, and that's something that's negative. And I think certainly there's a shift in the fact that actually being open and being, transparent to things and sharing vulnerability with colleagues or people that you interact with or you work with is actually seen as a good thing, as a fact that yes, and I think, and actually even patients they realize that there is a human side to doctors. So I think back again, how can you ensure that the training, particularly in fetal medicine, which is a specialty that sometimes on a daily basis you will give bad news, or you will be able to, sort of you will actually undergo, or sort of perform procedures like feticide, or actually have to, do procedures where maybe the outcome is not good, because not all the procedures are successful, and how you can actually maintain your compassion towards the patients, also your professionalism, and also the resilience of what you do. So how can you ensure that you want to maintain your technical skills, you want to get better in what you do, but also ensure that you need to look after the patient, because patients remember what you tell them. They remember every word. Also, they remember the way you tell them.
Yeah, very important.
And therefore, be very careful of what you actually communicate with the patient and how you be able to care about them and being there for them, depending on what they are going through, but also maintain your professionalism, and also being able to be the leader because often you will end up by being, you're the consultant, you're really the leader of the team, and being able to also provide the support to the younger members of the team, to other colleagues, and not just doctors, but also other members like midwives and other, and obviously your younger colleagues, where they might not have the same experience and the resilience that you have or you developed over the years. So that needs to be an integral part of the fetal medicine training. I think, as I said, it's becoming more and more common in major societies like Fogsi, like RSOG, like the equivalent in other countries, Americans, for example. Now, well-being of doctors or well-being of the healthcare professionals has become very important, and how we develop resilience.
Yeah. I think that has to be an integral part, because you start at 8 in the morning with very fresh, and if you're finishing at 8 at night, you should have the same sort of the rapport with the patient, or the way you experience. You might be tired, but you cannot show it to the patient about how you are anyway. But there are, as you said, there are challenges about access and training centers. So how do you think, in your opinion, institutions can make this fetal medicine training more accessible and equitable? Because that is something we notice in our country as well. So as you said, AI is coming in a big way. So how we can make sure that one person is receiving the same amount of training, or the same amount of quality training that we aspire for across institutions? Or do you have every person, because it may not be possible for one person to, because you cannot learn fetal medicine in a week or two. You need to spend some time, good amount of time, 3 months, 6 months, which is different, but it is a continuous process. So how do we ensure that training is maintained?
Yeah, I said fetal medicine is I think it's very difficult to rely on the fact that you just get up in the morning, go to work, do from 9 to 5, and come back home and sort of be a very good fetal medicine doctor. And I'm not sure that that's politically correct to say that. At the same time, we're saying about life-work balance and ensuring that people are not sort of at work until late hours. I mean, I was the generation where we did work really long hours, and that work was sort of your life, and that need to change, because I think that generations have changed, and really work-life balance is really important. But certainly, as I mentioned, fetal medicine is a really specialty where you need to be very good in scanning. So that's investment in actually technical skills and sort of improving imaging and being able to really scan at the high level. And also your knowledge, because you really need to have the latest knowledge. And a lot of the condition that, let's say fetal abnormalities or syndromes or genetic condition, they tend to be quite rare. And rare things, you need to be able to advance your knowledge all the time, be up to, and that's something that has recently become far, far more accessible and easier compared to the past, because now we have I call it the virtual revolution.
Yeah, true.
The revolution. And
that's also thanks to the COVID pandemic, isn't it?
Exactly. Is the fact that now, being ability to connect virtually on a daily basis. I will be connecting virtually with people from all over the world, than the States, Australia, India, Sweden. So, which that obviously that was not possible in the past, but also democratizing training and education by the fact that, there are many webinars, many of them are free, where actually people all over the world can be able to join and learn from each other. But it's obviously up to the individual clinician or healthcare professional to invest time and effort to be able to actually join and connect with that. So it's a two-way process. I think it's not, you cannot be just passive and everything will be spoon-fed or be served on a plate. It's even just being able to join these webinars, actively listen, learn, engage, ask questions. I think that's also active part, and therefore knowledge, being able to really have, and as I said, being up to speed with the latest advances like genomics, for example, or AI. And of course, in terms of the procedures, and many of the procedures that we perform or we have in fetal medicine, they are ultrasound guided. And the challenge that I said in the numbers and availability of training, because they tend to be centralized in certain centers. And therefore, there are really two philosophies when it comes to training in fetal medicine. One philosophy would say, well, if you want to be trained, they really need to go to this subspecialized, very specialized centers. And that means really significant investment from your time. You might have to have sort of fellowships. You might have to go outside the training. And often, you will need to really put a lot of time and effort to train to that level. And I said it's very competitive, of course, because available spaces or opportunities tend to be few. That's one philosophy. And then the other philosophy, which I think I'm more and more in favor of, is that there will be different fetal medicine specialists with different levels. And because the bulk of fetal medicine work or service provision actually is people who are fetal growth restriction, pregnancies that have fetal growth restriction, a small baby, or, following up pregnancy, let's say that the baby have an abnormality and being able to provide counseling. And there will be really very few that would require intervention.
True.
And therefore, we train the majority to be able to provide really good level ultrasound, making sure that they have the good knowledge, and the being able to counsel the patient, being able to train people how to provide compassionate and professional care, because that's not easy. So that's the majority. That's a large number of people that you'll be able to the screening, the sort of the genetic testing or genetic diagnosis and so on. And there will be a small number of people that will actually really need to perform that level of therapeutic procedures. And that would need to be in specific centers, because, these centers is not just one man show, really. It sort of needs a team structure. The people who actually would be able, the staff will have to support the operator in actually doing the procedure. The laboratory, when you're doing transfusion, it's not just one person who's doing transfusion, it's a whole thing about the lab and how to get the blood. And if you're doing a procedure, you've got sort of all the infrastructure of doing it. And that is difficult, at least at the moment, to be provided in every center.
That's very interesting, and I think it's a very good way of saying that, we can't have everything together, but have the majority of chunk doing what most of the patients need, and have a niche group of super specialists there who are providing this therapy. But I know you're working in AI, and it's coming up in a big way about training. So I wanted you to talk about that as well, and the way it is reaching to the unreached, and provide care as well as training. So can you just let us know about that as well?
Yes, and I think that's, I mean, I say that AI is a technology that's already changing our, even if you're not a doctor, you're using AI. I mean, look at the ChatGPT and sort of other AI platforms, and a lot of the stuff that you do, even like in a supermarket, and it's AI is becoming an integral part. And for in health or as a fetal medicine specialist, you need to embrace this technology, and you need to see how you harness it, how you can actually use that to improve your practice. And I said like it's already happening because most ultrasound machines already have AI integrated. But also, so I've recently led on AI position statement for his work for International Society of Ultrasound Obstetrics and Gynecology. And actually, there are very, very, very few organizations or societies that have developed an AI strategy or AI position statement, so that we really were at the frontier for that. And when we discussed it, and I've obviously did this work with other colleagues like Fatima Crispy and sort of other ISWOC trustees as well, how AI can actually improve the way we do it, but also I think we felt that we have a duty to train our members about AI, because it's black boxes, so there are different types of AI. Which ones, the low risk, the medium risk, the high risk. I'll give you example, for example, sort of, just for example, the low risk is sort of helping you with admin things.
Right.
So that's a low risk, correct? The medium risk, that it's actually helping you, maybe improving your diagnosis or, being more efficient, but you are the one who is checking everything for the AI. So it's an assisting. So it's operator-led, but AI assistant. And then the higher risk, where actually the AI can make decisions and sort of make diagnosis. I mean, things like it's regenerative AI, like ChatGPT, for example, is a regenerative AI, correct? So, and therefore it can generate things and sometimes can make up things. AI can make up references completely out of the blue. And I've seen it on several occasions. And so be very careful when you use a platform like ChatGPT, for example, this regenerative AI, because actually it can sort of make up things, and therefore you and also we discussed, so who's accountable if the AI makes a mistake? Who's accountable if it misses an abnormality or misses a diagnosis or gives the wrong advice? Who's accountable? Is it the AI algorithm? No, because the companies will always give you a disclaimer that, I suspect it will be the operator, it will be the healthcare professionals that are actually responsible at the end of, the day. So I think how, doing this risk classification or categories, the low risk, the medium risk, and the high risk, and therefore having different level of scrutiny on the AI in terms of validation and the governance, and where is the sources of the data, and how that can be actually used in everyday practice. So I think, yes, AI has become an integral part, and we need to embrace the technology, but it's still really its role and governance and all the ethics around AI is still work in progress.
Right.
So anyways, I think this position statement is about to be published soon, so hopefully that would be useful. So how do you use it in training? And there is, of course, a lot of things about like tele-monitoring, for example, but also like, for example, there is a platform where I could be in the middle of nowhere on my laptop, and I can connect, so let's say my fellow or my colleague back at work, or anywhere in the world, and the person is scanning and the patient is there next to the doctor, and I can see the ultrasound screen, I can access the dashboard, I can actually do measurements myself, I can be connecting to the person who's doing the scanning, and I also can have conversation with the patient.
Oh, fantastic.
correct? Which means that you can bring the expertise to the bedside for the patient, but also support the clinician or the healthcare professionals who is actually sort of there facing the patient doing the ultrasound scan. So, which I think is providing really fantastic opportunity for training and also for maybe, as I said, bringing the expertise to the bedside for the patient, where maybe in places where they lack the expertise. So, that's something that I think it's useful. And then also, as I mentioned, the training, having sort of this, the checklist approach or, the quality assessment where actually scanning and already the system have an image of let's say, you're supposed to demonstrate the spine, and this is how the views that you need to demonstrate the spine, or the heart, you've got the 4-chamber view, what structures you should be looking at, doing the 3-vessel view and so on. And actually when you are able to obtain the correct plane and the correct image that matches the standard, the system will become green, for example, or sort of have the green tick to say that you have obtained the correct image. So that potentially useful for training.
Right. And there is also a lot of focus on POCUS, right? The point of care ultrasound, which is also, so can you just, brief?
Yes, and POCUS is something I said, and I got interested in POCUS a few years ago, and I started sort of looking at it both from my researcher eye and brain, as how can I actually build the evidence and demonstrate that this is something that can improve the outcomes of the pregnancies, but also in terms of training, because I think POCUS is a game changer when it comes to ultrasound. Accessibility of ultrasound, particularly in areas where are remote areas, sort of the community where maybe, as I said, access, is miles away to get to a place where you can get formal ultrasound, shortage of sonographers, the fact that in Africa, for example, or certain parts of the world where, women in the villages, they don't have sonographers and sort of doctors that they actually can provide decent level scanning. So, and therefore that's where we became interested. But also if you combine AI and POCUS, I think that's a real game changer, because now, and it's been published, there are systems that are able to do that now. This is not the future, this is now. Where actually with the point of care ultrasound, which is like the size of your iPhone, you can, and even you don't need a doctor, you don't need even a qualified sonographer, where the healthcare professionals who actually have accessibility or goes and sees the patient, actually doing blind sweeps of the pregnant abdomen in a certain systematic way, like 8 sweeps. And it gives you information about dating of the pregnancy, for example, and the dating of the pregnancy is as accurate as a scan performed by a qualified sonographer, which is a game changer, because the data striking is two-thirds of pregnant women don't have access to ultrasound.
Yes.
Dating the pregnancy is extremely important, because this is how you define the prematurity. This is how you whether you need to give steroids or not. This is how you decide when you need to induce labor, so that you reduce the risk of stillbirth, for example. So they're very, very important. And now it is possible. And now there are systems that are able to perform that. But it's still, obviously, still work in progress, because you want to be able to have information about, the viability of the baby and the assessment of the amniotic fluid volume, placenta location. Postpartum hemorrhage or antepartum hemorrhage still remains to be one of the leading causes of maternal death worldwide. So one of the essential things, or sort of at least basic information that you need to know, where is the placenta? Is the placenta previa? This woman should have the section, should be delivering in a center where you've got access to blood transfusion and access to expertise. How many babies is there? Is it one or twins or triplets? So there is certainly a lot of, and even that biometry, even as, being able to identify, gross restriction or large gestational age. Again, the data shows that AI is better. It seems to be better than our traditional conventional approach of, measuring the head circumference, abdomen circumference, femur length, and using Hadlock to give us estimated fetal weight. So I think that's, again, I think watch the space. I think there is a lot of development. And I say the fetal medicine is one of the specialties that's always been at the frontiers and really sort of seeing the latest research and being able to implement it in clinical practice.
Absolutely. I think, and especially in India, where there is, as you said, there are so much of people who are not able to get even in one ultrasound. This is going to be a game changer. But you don't know about the practices in India, about the PCPNDT, the protection of the Perinatal Act we have. Do you think that will come as a hindrance for us? I mean, do you feel that? Because that is something we are worried that the people might take advantage, because there is still female feticide going on in India. So that is something we need to address it, especially if we consider it for training in our country.
Yeah. Yeah, I mean, I think this is when it comes to sort of the law and the regulations need to adapt to the technology, correct? So, and it becomes, how much benefit I'm getting from this technology for the greater good.
Yeah, true.
Compared to, the risk of sort of the potential abuse of this
Clearly,
technology.
the benefits are outweighing the risks here. So then if you look at it that way, because it is definitely a game changer. So how do you see this evolving? I mean, you're saying this is now today. So how do you see it evolving? And especially if you're looking at training, especially for fetal medicine, we know the Royal College sends obstetricians from India for training. But if somebody in India wants to undergo fetal training in the UK, what are the prospects now? I mean, because a lot of interest has developed in a lot of specialties in our trainees who want to do fetal medicine. And if they want to take up training in the UK, are there any prospects at all, or is that possible?
Yeah, I mean, I think that there are opportunities, but they tend to be really few opportunities and tend to be very competitive. Because, as I mentioned, it's sort of the centers that provide this training, there are few. And as I said, you've got obviously demand. I think it's sort of in terms of what type of training. And I sort of, again, in the last few years, I really try to champion democratizing training and trying to actually, it's training. Not everyone can actually travel, leave their family and their home and pay a lot of money to be able to come to UK or another country where they can actually spend a year or two doing a training fellowship.
Yeah.
And also I think there is a responsibility of the people who've been fortunate enough, maybe, have had the opportunity of having this training, when they go back to their country, to be able to actually train other healthcare professionals in the country to be able to disseminate knowledge and skills. So how can you ensure that? How can you ensure that not like if you have, let's say, 100 doctors in India that need to be trained in fetal medicine, can we actually send this 100 doctors to UK or to another country to be trained? Or can we send 2 or 3, and then this 2 and 3, when they go back, they are responsible for training this 100? And so I think how is that, how can you
more cost effective?
Yes, exactly, in a structured way. I think in terms of knowledge, I think that has sort of really, with the virtual revolution that we witnessed since the pandemic, I think to some extent that's happening. I think people, I don't think people will be short of access to knowledge from, the people who have the expertise. The question is the technical skills, and we said about simulation, but also we were talking about, can we do online simulation, for example? Can you learn practical skills virtually? And I'm not sure that we're there yet, but there's some development in this space. And then I think things like genomics and genetic testing was all about sort of the recent advances with the exome genetic testing, but also nowadays the whole genome sequencing, which as it is happening in many parts of the world, is coming in the UK in 2026, the introduction of the whole genome sequencing. And therefore, I think fetal medicine, they need to be integrated. And I, again, as part of my role of vice president with RSUG, we set up the genomic standing committee And I've been really very keen that we actually, and obviously I'm a fetal medicine doctor, so there is genomics obviously very important, fetal medicine, but also other specialties across women's health. So it's not just fetal medicine, but also, maternal medicine, it's also oncology, gynecology, and so on, other specialties as well. But certainly for fetal medicine, because it's already and has been integral part of our everyday practice for years. And therefore, fetal medicine doctors need to have a decent level of knowledge and understanding of genomics. So that will be able to interpret these results, because sometimes the interpretation can be quite challenging. And very important that you work very closely with obviously genetic specialists on a daily basis, and that's what happens in our practice here in the UK. So on a daily basis will be discussion with the clinical genetics about testing and about interpretation of the results and what does it mean, and how you can actually communicate this uncertainty to the parents, because that's a skill. It's a skill how you can be the compassionate doctor, supportive doctor, but also communicate uncertainty and tailor your advice and counseling depending on the parents in front of you. Because parents are human beings, they come from all sorts of different backgrounds with different expectations, beliefs, and anxiety about the uncertainty and their, what they want sort of long term. And also, their religious beliefs and so on. And how can you, with experience, and that comes with experience, but also nowadays people talk about actually having training, training the doctors who's going to do this job. So for me, I don't think we ever received training about how you do that, but you develop it with expertise, correct? With it over the years. But actually, how can we ensure that these doctors from day one are able to do that? And I mentioned earlier about the well-being, about resilience, because it will happen. Your career is long, and it will come across that you will face challenges in your career, stress, whether in your career or in your life. And how can you actually ensure that it doesn't have major influence on the way you practice? And if it's too much and you're not coping, maybe it's time to, I said, be kind to yourself and just say, look, okay, maybe I need to slow down a bit until you overcome this stressful period in your life.
Yeah. I think that's very important there. So if you have to design, I mean, you've done so much in training and you've been the forefront in that. If you have to change something in the fetal medicine sort of structured training as of now, what would you like to change? I mean, do you want to bring, I know this AI and focus is all coming up, but is anything else you would like to incorporate, which you think is lacking now in fetal medicine training, do you think?
I mean, I think it depends really whether the question is about globally or about the UK where I practice. Globally, I think really almost like not taking it exactly the same, because different healthcare systems have different setups, priorities, and challenges. But really, I mean, the fetal medicine curriculum, the training curriculum that we have here in the UK, that's obviously by the RSOG, is something that I think lacking in many parts of the world, where they don't necessarily have this structured competency-based training and assessment of fetal medicine. So that's an opportunity to take that and tailor it to your healthcare systems and what is needed in your country and what's available in your country. And really organizations or societies that have, overseeing the training of the doctors or that overseeing service provision to the patients should really champion that, because it's their responsibility to do that. And then when you talk about the UK, I think we do, as I said, over the years, we have really championed fetal medicine training. But is it perfect? I think it's very good, but certainly, as I said, we do have challenges in the UK, particularly with sort of training in diagnostic or therapeutic procedures. I think there's definitely a challenge at the moment. And then also, as I said, integrating genomics in the curriculum. And also how sort of your, this well-being of a doctor that's a particular specialty, where this specialty, because of the nature of what you do on a daily basis, can be adding extra layer of stressful work environment, or the healthcare professionals and doctors who are doing this need to have maybe an extra support, and they need to have this resilience built in their training as well.
Yeah. And as you said earlier, I mean, as we're working in a team, it's important that we all sort of speak the same language to the patient so that the patients don't get confused, when we are talking and and we all sort of meet together and talk. So as we're coming to almost the end of the podcast, what would your advice be? I mean, sometimes when you talk about fetal medicine, they get so overwhelmed. So much is there to learn and so much. So what would your advice be to an aspiring fetal medicine trainee, or wants to be a specialist? And do you think, I know in the UK it's different, but in India there's always this debate whether you can do obstetrics along with fetal medicine, whether you can still practice obstetrics, and whether you're doing justice to both your branches. But generally, as for trainees or young postgraduates who are coming out, your words of wisdom for them, in aspect.
Okay, so words of wisdom, or sort of, I don't know about wisdom, I think it's sort of what I learned over the years, is really follow your curiosity, and always learn, try to learn something new, try to lead with compassion, find a mentor who
Yeah.
is happy to support you and guide you throughout your career. And because I said that, I would not have reached where I am without really having great mentors in my career. Over the years, I really some of the legends in my specialty have been my mentors. So it's really important that you find someone who is willing and happy to mentor you. Always look for what's new and what's sort of the latest. Invest in your training, and also have your team, your team at work, where you can share the experience that you but also the challenges that you're going through, so that you can support each other. Because as I mentioned, fetal medicine can be quite challenging specialty, and being able to work within a team, and that means valuing the contribution of each member of the team. As I said, it's a very multidisciplinary team, and I believe that every member of this team have an important role to play.
Yeah, thank you. So thank you to Professor Asma, I mean, for your brilliant, so there's so much to learn from you in every aspect, and training is also, and you're helping it out in such a big way. So thank you so much. We're really looking forward to, in the future as well. I'm sure you're coming up with your guidelines, your training aspects, and you're coming to India. So we're looking forward to having you back in India in January, and many more times, but also looking forward in the academic front with your new guidelines and the position statement that's coming up on AI. So thank you so much for joining us, and thank you for this brilliant
Well, thank you very much, Sisa. I mean, it's been a pleasure really to talk to you, but also really just to congratulate you on the huge amount of work that you've been doing in fetal medicine, and the training courses, and these podcasts are fantastic. And I said, like, India has been really leading the world with several initiatives, and it's like, India has become the fourth largest economy in the world. And therefore, in terms of training in fetal medicine, I say India has the potential to be also a leader when it comes to training in fetal medicine.
Yeah. And as you said, it's not a one person, it's all a team effort. So it's the team that works best for us too. So on that note, thank you once again, and have a great day. Thank you so much.
Thank you very much. Thanks for having me. Thank you.
Bye-bye.